Hello, everybody, and welcome to this evening's webinar. I'm Craig Norman, and I get the distinct pleasure this evening to introduce to you and help moderate one of the most prolific optometrists, as far as I'm concerned, in the field of education, and one that has a high level of knowledge in many different areas, in particular the topic that we're going to be talking about tonight. Speaker is Barry Eiden. Barry is from the northern part of Chicago and has really accomplished many different things in his career. Besides running a phenomenal practice where he's medical director, he's the president and founder of the International Keratoconus Academy. He's also the co-founder and president of IVIS Eye and Vision Research Institute. He's a clinical professor at the U of I Medical Center in the Department of Ophthalmology, as well as adjunct faculty to half a dozen different optometry schools where he has been training their students for years as they pass through his practice. Barry's also the past chair of the American Optometric Association's Contact Lens and Cornea section and a fellow of the Academy and a fellow of the Scleral Lens Education Society. Barry, welcome. I hope you're doing great this evening. Myself and this large number of attendees are really ready and waiting to be educated on the OCULUS Pentacam tonight.
Well, thank you, Craig. It's really an honor and pleasure to once again speak on behalf of OCULUS, a company that I believe is really at the forefront of technology that helps us every day in clinical practice. I'm going to be speaking tonight about the utilization of the OCULUS Pentacam in optometric practice. And I've had the fortune of having a Pentacam at our office. I just kind of looked back and realized now that it has been over 15 years that we've had a Pentacam at our office. And time obviously flies by, but what I do realize is that it's a critically important element of our practice that we use so many times every day. And there are just a few instruments in our practice that honestly, if there was a problem with them and they were not operating, that I would have a hard time doing my job on a daily basis. And surely the Pentacam is one of those critically important instruments in our hands. So I hope to share with you some of the key points of how to utilize the Pentacam in practice. And those of you who are thinking about perhaps bringing this technology into your practices, I hope it really helps you understand the amazing number of ways that we utilize this technology. So I'll just start off here, just sharing a disclosure slide. I do consulting for a number of different companies, and OCULUS is one of them. I can tell you that for sure, the order in which my relationship with OCULUS started was I bought the Pentacam, fell in love with the instrument, and reached out to the company many years ago, telling them anything they needed from me to spread the word about the utilization of this technology, I'm in. And that's really how I got involved working with OCULUS over these many, many years. It started out with a phenomenal clinical experience with an instrument that I did purchase. So let's just start with the basics. What is Pentacam? Well, Pentacam is what we call a tomographer, and we'll get into the definition of what a tomography reading is in just a few moments, but it's a tomographer of the anterior segment. It utilizes a very specific imaging technique called Scheimpflug Imaging. So it utilizes the Scheimpflug camera, which again, we'll get into in a couple of moments what specifically it is and what it does. And it has so many, many clinical indications and applications that we utilize in practice. And tonight, I'm only going to be scratching the surface. I can tell you there are many, many other applications of this instrument, both in ophthalmological and optometric practice that are available. And it amazes me every day when I kind of look into the instrument, so to speak, of how many things are there that I haven't even begun to utilize yet. So let's back off from the Pentacam for just a moment and talk about something that others consider, perhaps equivalent, for lack of a better term, or an alternative technology, and that is regular corneal topography, or curvature-based placido-corneal topography. As we all know, that placido-based corneal topography utilizes a reflection system where concentric rings are reflected onto the cornea. The image is captured by the computer, and the spacing between those rings is used to calculate curvature values. So the closer the spacing, it indicates steeper curvature. The further between the rings, it'll be flatter curvature. So this gives you direct measurement of curvature data. And when you see elevation or height maps off of placido topography, these are derived from curvature data. Many of us feel that that may not be the best way or the most accurate way to actually measure true elevation of structures. And to be honest, there are many things as I approach clinically on a day-to-day basis that we just can't get from corneal topography that we do get from tomography. And that is, there is no analysis of the back of the cornea. It's only a measurement of the surface of the front of the cornea. There's no measurement of overall thickness of the cornea or global pachymetry. And this is important, as most of us understand that conditions like corneal ectasia, such as keratoconus, actually begin and progress greater on the back surface of the cornea. And by definition, we need to have abnormalities of the posterior cornea and of corneal thickness distribution, which we'll get into in a few moments, in order to truly differentially diagnose true ectasia or keratoconus from other corneal disorders. So just like this image indicates with an iceberg, there's so much that we don't see from the surface with topography that can really wreak havoc in our clinical decision making. So a tomograph is actually a process of generating a two-dimensional image or a slice through a three-dimensional object. And most of us are familiar with that from CT scans. So we're taking slices through the body when we're doing CT scans. And here we're doing the same through the anterior segment through the use of Scheimpflug imaging. So elevation-based anterior segment tomography, what are we talking about here? We are actually truly measuring directly the elevation of the anterior cornea, of the posterior cornea, and we derive curvature from this elevation data. And we've seen time and time again the accuracy of the curvature measurements that are derived from elevation data as compared to direct measurement of curvature with placido topography. We also get what we term global pachymetry. Global pachymetry tells us about the thickness of the cornea throughout the area measured, which with the Pentacam, we can measure out virtually the full thickness of the full diameter of the cornea. So how does the Pentacam actually work? Well, it uses a slit beam that creates a little slice of the anterior portion of the eye or the anterior segment of the eye. The Scheimpflug camera, which is located off to the side at a 45-degree angle, images those particular illuminated slices and creates, by putting together a multiple rotation of these slices, a three-dimensional reconstruct of the anterior chamber. The anterior segment of the eye. A second camera is used that actually is called the pupil or iris camera, and this detects movements of the head and of the eye and corrects for them. So that keeps things quite accurate. So we can see here in this animation how we get the camera imaging as the slices are reflected right there through the anterior segment. And then you get a multitude of these slices that can be reconstructed into a three-dimensional kind of construct of the anterior segment of the eye. And one of the things that you can notice, and we'll mention again in a moment, is as it's taking these slices, it's going purely across the anterior segment and across the entire cornea. So we actually are measuring, directly measuring the apex of the cornea. Remember, in placido topography, in the center of the instrument is where the camera is, and it's actually extrapolating that data in the very center. Even the curvature data is extrapolated from the data that surrounds that kind of blank area. I guess the best analogy would be like an optic nerve head creates a blind spot in our human visual system? Well, in a placido topographer, you have a blind spot, which is right over the center of the measurement area. So here is an example of a Scheimpflug image, and many of you who have not seen this before will say, man, that kind of looks like an anterior segment OCT, or at least a wide angle view of an anterior segment OCT, and it's very, very true. And they are both tomographs, or creating slices of this three-dimensional object. If, excuse me, if we dilate the pupil greatly, you can even see the entirety of the crystalline lens. Here is an animation of how the Pentacam actually works. And this takes just a few seconds. I actually had my own run a few days ago, and just reminds me of how easy it is to have it done as a patient. You can see the Scheimpflug camera off at 45 degrees from the slit being illuminated onto the anterior segment. Now, the Scheimpflug imaging is based on a photographic principle developed by Scheimpflug over 100 years ago. This is not new technology in terms of Scheimpflug photography, but its application in the Pentacam obviously is modernized to a great degree. And in essence, what Scheimpflug photography does is extends the depth of focus. And that's what we want to do. That's how we're getting an image from the front of the cornea all the way through into the anterior chamber, to the iris, and beyond into the crystalline lens. So we really get a full image of the anterior segment of the eye. So the benefits of Pentacam is that we get this detailed analysis of the cornea, both the anterior and posterior aspects of the cornea, the anterior chamber, and the crystalline lens. And as I mentioned, these images do directly go through the central cornea, and you're getting direct measurements of the portion of the cornea that relates directly to visual function. And now, compared to most other placido-based topographers, the Pentacam can give you much greater measurement area. It actually can give you limbus to limbus coverage and actually beyond. Now with the new corneal scleral profile software available in Pentacam, which we'll talk about a little later, you can actually now get not only corneal shape and elevation measurements, but corneal scleral. And so similar to some of the other profilometers that are out there, we're able to get the entirety of the anterior segment shape. The other thing to mention about is the fact that with this, with the direct measurement of elevation, this elevation data almost never is affected by the tear film itself. And so we get really great elevation data regardless. I have termed the Pentacam a topographer on steroids. It's obviously not a topographer, it's a tomographer. But I call it a topographer on steroids because it does so much else other than measurement of corneal anterior shape. Again, using Scheimpflug imaging, measuring the front, the back of the cornea, full corneal thickness. It does optical densitometry, so it can give you values of opacities in the media that it measures. It can do aberrometry, and the standard Pentacam will give you all corneal aberrometry, but you'll see there's a new version that gives you all forms of aberrometry. It has IOL planning programs, contact lens design programs, glaucoma analysis, and so much more, and we'll go over this in more detail as we go forward. So let's start out with what most of us in optometric practice are mostly concerned about. That is measurement of the cornea. As I mentioned to you before, with Pentacam, we're measuring not only the front of the cornea, but we're also measuring the back of the cornea in terms of elevation and curvature, and we get global thickness readings as well. The classic display is called a 4-map refractive display. And most of the time, the way we display these 4 maps are in this way. In the upper left-hand section, you can see me kind of outlining it here. That is the sagittal curvature or the axial curvature, something that all of us should be very familiar with based on our placido topographers. That gives us that type of corneal curvature reading or axial curvature. In the upper right corner, that's elevation data. That's elevation of the front surface of the cornea. Down below on the right is elevation on the back of the cornea. And in the lower left is your global pachymetry map. Keep in mind, with any of these readings, whether they be curvature values in diopters, elevation values in microns, or millimeters of corneal thickness, you can put your cursor when you're at the instrument or at your computer that's attached to the instrument in your exam rooms, and you can click on any part of that map and get a number. So if I wanted to know how thick it was here, if this was a live reading, I'd be able to click on it and it would show up as a number. There are a whole host of values quantitatively that we get on the 4-map refractive, some of the key ones being SIM-Ks, asphericity values, pachymetry values in terms of what is the thinnest point on the measured area, what is the thickness at the apex or the pupil center, and the Kmax, or the steepest curvature on the front surface of the cornea, among others. It'll also give you corneal diameter readings or white to white readings as well. Now, when we talk about elevation, since the Pentacam is an elevation-based system, we want to know what we're talking about. First of all elevation maps are relative maps, and they have to have a reference surface. And you can set that reference surface in the Pentacam to a number of different reference shapes. You can set it to being measured against a reference sphere, or a reference ellipse, or a reference toric ellipse. There's all reasons why you'd want one versus the other. Most commonly, the reference shape for elevation on the front and back of the cornea is compared to a reference sphere, because that really can show you more about toric surfaces or aspheric surfaces or irregular surfaces. And the way the maps are set up is that warmer colors indicate more anterior elevation towards the front of the eye. Cooler colors, more posterior elevation. And the reference color is green, typically. Now, here's an example of a 4-map refractive of a keratoconic patient. We can see how different that is versus the normal patient that I showed you before. Here in curvature, showing that inferior steepening. But the elevation is what I want you to look at, because we see the true apex of the cone, or the most anteriorly displaced portion relative to that reference sphere that's created, is abnormal. But you also see that the back elevation is abnormal, and you see that the color and the numbers are actually greater. What this indicates is that the posterior cornea in keratoconus is more anteriorly displaced than the front of the cornea is, than the anterior portion. That makes sense, and they should be in a coincident location in keratoconus. Why does it make sense? Because that makes the cornea thinner. If the back is pushed forward more than the front, at that location, it is going to be thin. So you should see these 3 points agreeing in location: anterior maximum elevation, posterior corneal maximum anterior elevation, and the thinnest point. And we can see that that thin point is decentered from the center of the pupil, also quite typical of keratoconus, and is of a value that is surely abnormal, the thinnest point being at 438 microns in this example, as you can see. Again, steeper SIM-Ks, look at that Kmax at over 53 diopters. And we often can see, depending upon the location of the cone, higher degrees of prolate eccentricity. So here are some examples of 3 different elevation maps. These happen to be from the front of the cornea, could also be from the back of the cornea. You can see the elevation of a sphere staying all green. You can see the saddle shape and 90-degree separation of normal regular astigmatism. And you can see that localized elevation anomaly in keratoconus and corneal ectasia. And that typically also is where the thinnest point of the cornea is going to be as well. So we can see here a normal cornea with the rule astigmatism on curvature, with the rule astigmatism on elevation on the front of the cornea. Notice that the steep meridian is warmer when we're talking about colors and curvature, but actually cooler when we're talking about elevation, because it's more posterior. It's sort of dropping off, if you want to use that term. And notice that in a normal eye, the anterior and posterior corneal Elevation maps show a very similar pattern, and that's quite normal as well. We see the thin point of the cornea being fairly well centered and of a normal value in a normal cornea. Here is an interesting one. If we look at the front surface curvature, nothing seems that abnormal. If that's all you saw, you would consider it probably a normal case, although there's some degree of superior-inferior asymmetry in curvature. The elevation map on the front, again, showing a 90-degree astigmatic separation. That looks pretty normal as well. But surely on the back of the cornea, this is an abnormal posterior corneal elevation. We could see that similar point and location for the thinnest part of the cornea, and that thin point is thinner than a typically normal or average cornea will be. And this is a case of an early subclinical form of keratoconus. This patient probably has 2020 or 2015 best corrected visual acuity, probably has no symptoms at all. It may even be the fellow eye of a truly keratoconic eye. And that's why we've thought in the past that we're dealing a lot with unilateral keratoconus when we're using placido topography, but with tomography like Pentacam, we realize that keratoconus is not a unilateral disease. In the vast majority of cases, you'll pick up something in the contralateral eye. And we can get deeper into the weeds on the fact that I believe that keratoconus for sure is a bilateral disease, even if the Pentacam is normal in one of the eyes and abnormal in the other, but that's for another night to talk about. So now we see more of a moderately advanced keratoconic with abnormalities of anterior curvature, anterior elevation, posterior elevation, and global corneal thickness. Let's talk about that global corneal thickness element now, because it's really interesting. Not only do we find out what the thinnest point in the cornea is, but we learn from these maps, these global pachymetry maps, what the status is of thickness distribution. And it is abnormalities of thickness distribution, meaning the change in thickness from the center to the periphery, that really differentiates true keratoconus and corneal ectasia from just normally thin corneas. And the global consensus paper on keratoconus that was published in Cornea in 2015 actually stated that the thin point of the cornea is one of the least reliable differentiators or indicators of keratoconus versus non-keratoconus. It is the distribution or change. So how does this instrument measure that? Well, it actually creates these concentric little rings and measures these concentric rings from the center out to the periphery. And each ring is averaged in its thickness, and two critically important displays come from these measurements. One's called the corneal thickness spatial profile display, or CTSP, which is really a measurement of absolute thickness of the cornea in microns from the center to the periphery. And the other is the PTI, or percentage thickness increase. And that tells you about the rate of change of corneal thickness from the center out to the periphery. And you can see there are these black dotted lines. The center reflects the mean, and then you have two standard deviations from the mean going from the center to periphery. The patient's actual plot is the red. And you can see in this particular case, we have a normal eye. Their corneal thickness absolute measurement as well as their PTI fall within the normal range and is considered normal. But let's take a look at this case. Here's a case of a mild keratoconic. You can see an inferior steepening, maybe a borderline anterior elevation anomaly, just a little bit on the abnormal side, more prominent posterior anomaly, again, not atypical. But here's something interesting. Look at the thinnest point on the cornea. It's actually 523 microns. So you have a statistically normal thin point with obvious corneal ectasia. Let's look at those corneal distribution maps. We can see that the absolute thickness falls totally within the normal range. So if one was just measuring the thickness of the cornea at the thinnest point or even in the center, this patient would come out normal. And you might say maybe this wasn't keratoconus. But the truth is, look at the change in thickness here from the center to the periphery. It thickens at a faster rate than normal, and it's outside that 2 standard deviation criterion. This is definitely abnormal. So We know from looking at the maps, but here we see how sensitive this PTI is at picking up ectasia. Here's a more advanced case where the actual thin point goes outside of the normal range and a more dramatic abnormality of the PTI. Well, let's kind of go off on a little tangent here because I always find this interesting. How many times I see posted on all our various Facebook groups, whether they be scleral lens practitioners or so on and so forth, all these cases, oh, look at my case of PMD, pellucid marginal degeneration. Why do they call it PMD? They call it PMD only for one reason. They look at curvature maps and they see the classic kissing doves or crab claw pattern. But the truth of the matter is the vast majority, well over 90%, 90 to 95% of these cases are not PMD. And how do we know that? Because you look at global thickness. We know that by definition, PMD has localized inferior, typically inferior corneal thinning in the periphery, about 1 to 2 millimeters in from the limbus. But here we can see the thin point is definitely not anywhere near the limbus. We could see the abnormalities in elevation on the front and back of the cornea, but that classic crab claw or kissing dove pattern. Let's look at a case of true PMD. In true PMD, especially when we use the global thickness map and we expand it, and this one's expanded out to 12 millimeters, you see that inferior area of thinning. And you can see that on the vertical cut on the Scheimpflug image. You can see that localized area of thinning. This is true PMD. Most of the cases that we see those crab claw kissing dove patterns are pseudo PMD and actually are truly keratoconus, even though many people consider true PMD still to be in the kind of the family of keratoconus. Here's another example of true PMD, that inferior thinning, and you could see it on the vertical cross cut as well as on the expanded global pachymetry map. Here's another interesting thing that we do with Pentacam, and we do that also with placido topography, which are difference maps. So we take two different measurements and we create a difference map. Here's an example, one of our patients that presented with corneal hydrops, and you could see how thick that cornea became, but after resolution resumed kind of closer to normal keratoconic pattern. And here we can see the difference map between the two. And we use this difference map often for monitoring for change over time, especially looking for progression of keratoconus. Talking about detection, early detection is obviously very, very important of the disease and differentiating normal versus abnormal prior to a decision going forward with refractive surgery, for example. Well, an amazing software in the Pentacam has been developed over the years, and this is the third generation of the Bellin-Ambrosio ectasia detection software made famous by Professor Mike Bellin and Renato Ambrosio, who developed this software. And basically, without going into great detail, it's statistical analysis to determine if a Pentacam reading is actually indicative of ectasia. And this is the point I want to bring out to you. The only information that's used in this software is elevation and corneal thickness data. No curvature data is used in this software. This is for detection of disease. As we'll see in a few moments, different values may be better for detection of progression. And we know through evaluation and study that this is an amazingly sensitive and specific test. And it utilizes a number of different values calculated from front and back surface elevation as well as global thickness to create a statistical value called the overall or final D value. Any of these values are indicated in white when they're less than 1.6 standard deviations from the mean. When they're 1.6 to 3, they're considered borderline or yellow. And when they're red, they're over 3 standard deviations from the mean. That is really a criterion that one might want to be a little bit more suspicious of, especially in patients who are at least 2 standard deviations or more from the mean, which is something we more commonly will use as a criterion. So a lot of these quote unquote yellow values are still something to be very concerned about. But the point being here is that this software is amazingly sensitive and specific for detecting ectasia and keratoconus. For looking at other values for detection of progression, we do look at some curvature values, things called the ARC and PRC. And the ARC is a measurement of the corneal curvature on the front of the cornea in an area about 3 millimeters around the thin point. The PRC, or the posterior curvature, is actually measuring the same area, 3 millimeters around the thin point, but on the back of the cornea. And the final value, called the C value, is the thinnest point. And we utilize this kind of information not only for staging severity of keratoconus, but also for early detection of progression, which I'll show you in a moment. The D value, because in the paper they talked about the ABCD criterion, the D value is actually best corrected spectacle acuity. When you're doing a spectacle refraction, what's the best acuity? You can put that in there as the fourth of the values. So we can see here a normal eye, and we can see those ABCD values are quite minimal, good corrected acuity. We can go to very early corneal ectasia, little thinning, slight elevation anomaly, and you can see those numbers start going up. We get concerned and we think positive typically is over 1.0 in any of these values, and we can see some of them are actually exceeding the 1.0 value. And a more moderately advanced case, you can see those values take off, in a very advanced case even be higher than that. And here is an example also in the software. Mike Bellin developed the Bellin progression analysis. It looks like quite an amazing thing to look at. And actually there's a new version of it that incorporates some statistics following cross-linking. We don't have time to go into the details, but it utilizes these values I was just talking about in terms of being able to detect true progression of disease. Now, why is it so important to be able to detect early this disease and surely to be sensitive to detecting progression? Because as we all know, we can stop progression in the vast majority of cases with corneal cross-linking. And therefore, if we catch these things early enough and intervene early enough, we're going to preserve patients' vision. This is the mantra that we all really work under when we specialize in dealing with patients with keratoconus. Other things that can be done with the Pentacam include just using it for anterior segment imaging. Let me just share that. Here's one of my more advanced, if not my most advanced keratoconic patient. He happens to be wearing a prosthetic impression-based scleral and still sees 20/40 plus in this crazy eye, but that's a lot of elevation and quite a thin cornea. If you take a look, he's under 100 microns at the thin point and over 100 diopters in Kmax on the front of the cornea. It's pretty amazing, but he definitely does not want a corneal transplant. He's kind of dead set against it, happy with his vision, able to tolerate his lens all day long. Here's one of the cases of high drops that we see. We could see the thickening of that cornea in this imaging, and then following it to its resolution, same eye after it was resolved. So it went from here to here. Again, utilizing the change analysis or difference maps. If you have cases of diffuse corneal edema and you're treating it, you can see how it's responding to treatment in terms of changes in corneal thickness using those difference maps. Another interesting aspect that's in the Pentacam is the ability to utilize their contact lens fitting software. So within the Pentacam and based upon the measurements, you can virtually design contact lenses. You can actually use a whole host of predetermined proprietary designs, or you can actually do custom designs as well and get simulated fluorescein patterns. If you press the geometries, you can actually see all of the values of the peripheral curves, the central curves, and you can see that tear film analysis and modify them accordingly. The other thing you can do with these contact lens fitting softwares is link up to a variety of labs where you can actually send in orders or have changes made to design based upon these simulated fluorescein and lens design patterns. Here's an example that using the Pentacam data to design a corneal lens using the Wave software. Many of you are aware of the Wave technology. Wave is a company that makes highly customized contact lenses, predominantly corneal lenses, but now expanding into scleral lenses as well. You just click the external software and you press on the Wave button that you've downloaded into your system, and you get their software coming up, and you can make all kinds of manipulations and design corneal reshaping lenses. You can design regular lenses for keratoconus. You can design multifocals off of this software and such. Another software that interacts with the Pentacam that I've used numerous times is the iSpace. And I've used iSpace to design corneal reshaping lenses, as well as some other types of corneal lenses additionally. Again, talking about corneal reshaping, the use of those difference maps is, again, very, very helpful. As we can see here, a pre-treatment, a post-treatment, you see the flattening, and now you can truly see what the actual change in refractive power, or you can do axial curvature, any of the values you want, elevation or whatever. Very, very helpful in determining how your treatment is actually taking its effect. Another thing you can do with the Pentacam is actually measure the sagittal height of the cornea. And there's a variety of ways to do this in the software. And I know people who utilize this data in actually designing scleral lenses in a very much more customized way. We'll talk about this a little bit more. And we can see also, if you wanted to, for those of you who may not utilize anterior segment OCT for the assessment of scleral lens vaulting, you can do that with the Pentacam, and you can actually measure the vault measurements. And here you can see one with about central vault of about 350 microns. Here we can see an excessive central vault of over 1,000 microns, but where the lens comes jamming down on the limbus and actually bears on the limbus. So one can use this technology for that purpose as well. So that kind of leads us into the exciting, relatively new area. We've worked on this for the last couple of years, which is the Pentacam CSP software, or corneoscleral profile software. It's elevation measured. You don't have to add fluorescein. You're just taking direct elevation measurements of the anterior segment surface with the Pentacam, compared to some of the other profilometers that are out there, like the Eaglet or the I think it's the ESP as well, that's out there. The CSP software in Pentacam can measure out to about 18 millimeters of ocular surface, and it takes 50 images in one of 1, 2, 3, 4, and 5 sections. The person doesn't have to look in different directions, but it's measuring the center, the superior, inferior, nasal, and temporal. And it takes a few minutes to run this, but it all comes together quite nicely. And it's all done in primary gaze. Again, the person doesn't have to look up or look down or look left or right, which can actually create some artifacts and some erroneous measurements in some other technologies. It does not require, by the way, a different scan from the CSP scan to get the normal corneal data that you get out of Pentacam. So you get when you run a CSP, you get the regular Pentacam data plus the scleral elevation data as well. And here you can see the CSP kind of display. These are all the various different sections that it measured. And here it shows you the center, superior, inferior, nasal, and temporal areas. And we can apply the Wave software as well as other software to this as well. And here you can see in the Wave software designing a scleral lens based upon your CSP data. Here we can see that once again. I'll show you a little bit in terms of a video of how it's working with that Wave software. So just watch this for a second, and you'll see the instrument is actually, through the software, taking that elevation data from the CSP. We're putting in the spectacle plane refractive error, so it can actually calculate potentially the power as well. And then it's going to go to the tools section, go to corneoscleral lens and create a design, and watch. We're going to click what the corneal diameter is, what lens diameter you want to use for that corneal diameter, and how much central apical clearance your goal would be. And then it just does its thing. Watch it. It's kind of cool, just watching the whole process, and you see this actually happening. And it actually develops, when it gets to step 4, what it considers to be an appropriate lens. And you have the ability to kind of rotate and look at various meridians. You'll see that happening right here. And by looking at various meridians, you could decide if I want to modify it in some way or another. And as we can see, we're able to make modifications. We can modify central vault, we can modify limbal clearance, or the angle of landing as well. And we can do so in meridians or in quadrants as well. So you can do quadrant-specific changes to all of these in a more customized design. And that's the CSP fitting software. There's a whole host of things you can do with that. That would be an hour talk on its own, to be honest with you. Let's talk about a couple of other things that Pentacam can do. We utilize it all the time as a virtual gonioscopy instrument, that we're measuring anterior chamber angles in patients regularly. And this has increased, I have to be honest with you, the number of patients that we perform LPIs on, because otherwise we didn't realize that they truly might have been at risk for angle closure. So we're able to get the anterior chamber measurements of the angle, anterior chamber depth, and also anterior chamber volume. All of these things can be measured through the Pentacam 360 degrees. And when we see patients who have an anterior chamber angle approaching 20 degrees or less, anterior chamber depth and anterior chamber volumes under certain specific magnitudes that would concern us, then we put actually on a physical gonio lens and really examine the angle in more detail to determine if we want to move forward with an LPI. A nice tool that can be used is what's called the fast screening report from the Pentacam. And it will show you in one kind of gestalt view all these different measurements and if your patient's values are actually in the normal range. For example, here you can see the anterior chamber angle at 19 degrees is outside of normal, okay? Where here, corneal densitometry value is well within normal. We can see that red being pathological or abnormal, green being normal, and then you get some overlap for sure between the two populations. I want to go back here because throughout the Pentacam, there's so much information. You can actually right-click a lot of these things. They will either give you definitions of what these measures are or actually references for you to learn more about them. There's so much information in this instrument that is available to you. Here we can see a normal eye, and you can see all these different measurements fall within the normal range. You can see them here. This is a little bit outside. And then if you go to somebody who has a potentially occludable angle, we can see that the patient falls outside of that normal range. So we're getting towards the end of the presentation for this evening. Again, I only wanted to give you a taste of what it can do. I actually haven't scratched the surface. There's so much that can be done with this instrument. There are basically 3 models available to us currently, with a 4th coming on board and has come on board for some of us and will come on board, as you'll see in a moment, for the rest of us soon. The standard Pentacam, the HR version, which is high resolution, it gives you a little bit more detailed imaging in the Scheimpflug image. And then the AXL, really, which is very, very exciting, because the AXL not only does Pentacam measurements, but also gives you biometry, or very detailed and very accurate axial length measurements. For us in optometry, we would utilize that for our cataract patients in providing that information to our surgeons for cataract surgery. But even more exciting is the ability to utilize this for myopia management. So that really makes the instrument a 2-in-1 instrument. Well, let's take that to the next level. The newest instrument that just came out is called the Pentacam AXL Wave. The current model that's out there is really heavily weighted towards cataract surgeons in the software. However, coming soon, Oculus is developing a version of the AXL Wave which will be oriented more towards optometric practice. And what differentiates the AXL Wave is that not only does it include the basic Pentacam tomography and the AXL aspect of optical biometry for axial length, but it also incorporates wavefront aberrometry of the entire ocular system, as well as objective refraction and retroillumination. So basically, through the information that this instrument gives you, it's doing multiple functions. In our office, this instrument will replace 3 current instruments. It'll put them into one. It'll take our Pentacam, it will take our OPD aberrometer, and it will take our IOL master for axial length readings and allow me to have one instrument that can do all the functions and actually more than either of those 3 put together. And here we can see an example of taking a Pentacam, an IOL master, add that to an autorefractor and an aberrometer like the Tracy iTrace here into one unit. And to me, one of the really exciting aspects is my current aberrometer helps me differentiate anterior corneal aberrometry abnormalities from everything that's posterior to the front of the cornea. That's great, but the posterior to the front of the cornea can be induced by cataracts, or it can be induced in my keratoconic patients by abnormalities of the posterior cornea. I have no way of knowing currently with my OPD system whether or not those hyoid aberrations that are called internal are due to the back of the cornea or an early cataract in some of my older keratoconic patients who are also developing cataracts. But this instrument, because it can measure the elevation and shape on the back of the cornea, can actually separate that out. It can tell us what the front of the cornea is contributing to hyoid aberrations. It can tell us what the back of the cornea is contributing to hyoid aberrations, and then what's left over is typically lenticular. So to me, for our keratoconic patients who are developing cataracts, it will give me much greater detailed information on being able to differentiate what hyoid aberrations are being induced by the cataract versus the typical keratoconic back portion of the cornea. So I find this really exciting, and I'm hoping to bring this technology into our practice very, very soon. That being said, in summary, Pentacam is actually not just a topographer, it's truly a comprehensive anterior segment analyzer that has so many clinical utilities that honestly, I can't go a day without utilizing it. So I want to thank you at this point, and Craig, I'm going to let you perhaps look at some questions that might have come in. If any did, I don't know. I'm happy to answer some since we still have a couple of minutes left.
Thank you, Barry. And I'm going to speak for all of the attendees. Thank you very much. For me, I know that anytime I attend a webinar or a lecture, I'm looking for just one tip to take home, and I have a handful of them from tonight. So thank you from that for sure. We have a bunch of questions, and I would really suggest for the attendees, if you have a question for Dr. Eiden, please type it into the chat box. Meanwhile, would suggest to you also that you stick around for a little while, because I think there's some real interesting things that have come in. Barry, before we get started, I want to just address 2 issues. One is I was reflecting on looking how sophisticated the Pentacam is today, and I was reminiscing about my first corneal topographer was a corneoscope. And how at that time I thought this was going to revolutionize everything. And man, in just a few decades, how much it's changed is really incredible.
Yeah, and think about just how the Pentacam technology has developed over the last 10 years, and that keeps going forward. So it really is exciting.
Yeah, exactly. The other thing I noticed, and I've had this conversation with a number of eye care practitioners over the last couple of months, is related to being able to acquire so many measurements that we want today for specialty lens fitting. And in particular, we think in the area, not just scleral lenses, but ortho-K, and trying to understand myopia management as much as we can as we're getting more sophisticated here. And one of the things that often pop up from the practitioners is they're worried about too many instruments because they have a large footprint and they don't have office space. And it sure appears that the Pentacam can answer so many of those in one instrument.
No doubt. I think that that's critical. You know, we don't want to give up, let's say, the quality of the information that we get by putting them together, kind of like a all-in-one contact lens solution. Sometimes we think, is it as effective? But when it comes to this instrument that I was just sharing with you, the AXL Wave, we're not giving up 1 ounce of information. In fact, we're just adding to it. It's very exciting. Very exciting.
Yeah, exactly. So let me start off with the relatively practical question. This one came in and it is asking, how easy is the instrument for technician use?
It's extremely easy. See, at our practice, and you alluded to this fact earlier, we do have interns from multiple optometric colleges that rotate every 3 months through our practice. So every 3 months, we have to retrain a whole new group of interns. We'll have anywhere from 3 to 5 at any one period of time at the practice. We have to retrain them in all of our technologies. And then one of the most important is the Pentacam. They get it almost immediately. This is really not a hard instrument to use. That being said, Craig, I don't know how to use it. I've never actually run the damn thing.
Right.
I know how to interpret it, but actually it's only my techs and my interns. So,
well, it makes sense though. You're the diagnostician here. You don't need to know how to push the buttons. You need how to
if they want to go on strike, I'm screwed.
Yeah. Okay. That was really great. We had a couple of questions related to Pentacam versus a topographer. You know, one is related to the fact that using the Pentacam, does it displace completely the topographer in your office? Or do you still use topography?
Okay, so let me tell you what we have at our office. We have a Pentacam. I have a keratograph, and those of you who know the K5 keratograph by Oculus is a Placido-based topographer, but it also has tremendous other additional software. And we have our OPD, which has integrated Placido topography within the aberrometry. We virtually never use our keratograph for topography because of our Pentacam. I don't need it. There is no function that I see that I cannot get off of my Pentacam that I can get off of a Placido topographer. I do use it in our OPD for aberrometry, but I will tell you, if I end up getting the AXL Wave, I'm not going to be using any Placido topography, to be honest with you. I don't see any function for it.
Okay. Excellent response. Here's another practical question, and thank you for sending this in. How do you work the Pentacam into the exam flow? Is it a global pretest screener, or exactly how do you use it?
So that's a great question, actually. At our practice, I will tell you some of the ways in which, or some of the types of patients that we run Pentacam on. Every contact lens patient, every annual visit, and as needed, between their annual visits. Surely we get a baseline, and every year we run the Pentacam because we want to see what's going on with global thickness. We want to see what's going on with curvature and elevation. So that's for sure. Any keratoconic, obviously, or any keratoconus suspect, or any family member of our patients with keratoconus, and that's an important point. I individually see 5 to 7 keratoconics a day. I know that sounds crazy, but that's what happens when you start taking care of these patients. And one of the most important things we ask these patients is, do you have any children if they're adults of that age? Or do you have any siblings? When was the last time they were examined? Were they told they have keratoconus? So we bring in family members all the time. And if they're young enough, we're going to continue to monitor them. And of course, we monitor them with Pentacam. We'll also utilize it, as I said, as a kind of a virtual gonioscopy that we run all of our patients who are glaucoma suspects, or some of the folks who seem to on slit lamp have relatively narrower angles. We'll run those as well. Patients who have gutata or early Fuchs. We want to see if their corneal thickness is changing over time. You don't want to use, if you have the choice, a ultrasonic pachymeter. You're only measuring one point. You can do global corneal thickness this way and do change analysis over time. So those are just some of the patients. Add to that refractive surgery patients, prospective refractive surgery patients, and then on an annual basis, following up those who have had LASIK or PRK or RK. We do that as part of their exam. So, you know, in terms of, if the question relates to how do you charge for it, that kind of goes a little beyond what we're going to talk about today. But just to give you a taste of that, all of our contact lens patients are charged a contact lens diagnostic evaluation fee, and the Pentacam is part of that fee. So we're not actually charging for Pentacam in essence. It's part of something else.
Okay, so that wasn't, I don't think it was a fee question in particular, but that's really a great heads up. And by the way, this whole thing about looking at the angle to me is extremely fascinating. To be able to get that kind of picture of understanding in a workup phase is incredible.
Yep.
Let's talk about contact lenses for a second. When fitting scleral lenses, does the Pentacam replace the need for a trial set, or does it work in combination with the trial set? What's your view on that?
That's these are great questions. I don't know if you're making them up or is it our audience, but
well, I'm making up all the really great ones.
Oh yeah, exactly.
Yeah.
That was a great question. So of course, you know, Craig knows me very, very well. There isn't a toy that I can resist. So we have the profilometry systems in our office. We have the CSP software, and we have a ton of fitting sets. We're pretty damn good at fitting off of fitting sets. And the truth is, when you're virtually fitting, which is great, especially for the more irregular shaped eyes, you still need to put a diagnostic lens on for power. That's the bottom line. You cannot predict what the power of the lens is going to be. So whether we're doing profilometry, CSP, or even impressions, you know, like iPrint impressions or iFit impressions, you still have to put a diagnostic lens on at least for power.
Yep.
So I would say at our practice right now, when we're fitting sclerals, this is a guesstimate, probably at least still 70 to 80, 20 in favor of diagnostic lens fitting, but moving more towards the virtual fitting. We thought that with this whole, you know, COVID thing and pandemic, it was going to force the issue of virtual fitting, but the truth of the matter is, I'm not so sure it really pushed it that much further.
Yep. Okay. Had a really nice comment come in from Tom, who talked about how the AXL and Wave has basically replaced all this Placido topography and eliminates lash shadow, which of course is a big deal with Placido topography. So that's an excellent comment there as well. Then what about, this is an interesting question in itself. Can you ever consider using the Pentacam to view scars that are in the cornea?
Yes, I mean, just like you can with anterior segment OCT, obviously the Pentacam HR is going to do a bit of a better job because it's just higher resolution for the Scheimpflug image. But yes, you absolutely can.
Okay. I want to make a quick comment that your notes about PMD are really kind of interesting. I think about early in my career when any time that we would hear about pellucid, it was like an oddity. And then with the more common use of topographical and surface measurements, it became like an quote unquote epidemic, right? And I think your comments there were really spot on. I did want to ask you one other thing related to the Pentacam though, is there ability to measure the line of sight?
You know what? I truly believe there is. So you're talking about for multifocals and things like that?
You know, we're hearing so much about, you know, displaced optics, right? And so is there a way to be able to use the instrument to aid in choosing exactly, where those optics might be?
I haven't utilized it, but I'm aware of it, and I'm almost positive the answer is yes. For those who want an absolute answer, feel free to email me, and I can give you the email address if you want, and then I can do the research. But I know that I'm almost positive the answer is yes.
I think it is as well, and that it allows you to be able to look at that line of sight / angle kappa, right? Just getting an idea of exactly where it might be.
Yep.
And it, if so, really could prove beneficial as we go forward about these displaced optics.
Mhm.
So we asked about the ability to image relative to corneal opacities. What about for lenticular opacities?
Yeah, so there's a function called densitometry I alluded to earlier, and densitometry will give you it's an arbitrary scale of 0 to 100. It's not like it's really some number like lumens or something like that, but you can put the cursor with the instrument on an opacity. It will give you a blip on the densitometry graph, and it will give you a number from 0 to 100, and you can kind of monitor it for progression on a quantitative basis.
Do you view that at all as, besides being a diagnostic tool, that it might be a patient education tool as well?
Oh, for sure. That's actually, I use it more for that purpose than diagnostically. I know that there's a cataract there or there's a scar, but when I show the patient, very often cataracts, this is something that we show our patients all the time with the Pentacam, because the opacities in the lens will show up on these scans, especially after you dilate them. You'll see them very clearly, and you'll just point to that and you say, you see, you were complaining about your vision in the right eye. You see the way it looks different from the image of the left eye, more of these opaque areas. So yes, educationally, it's fabulous. Remember, we review all of these results as well as many other instruments in the exam room in front of the patients, because all of our instruments, for the most part, are networked. And so I never typically go to the room where it's actually being done. It's all done in the exam room in terms of analysis and education.
Yeah. Well, obviously, as you had mentioned, since you have an inability to run the machine, the technicians don't want you in the room as well.
Yeah, for so many reasons.
Yeah. So anyways, I think that the education part about the ability to look, whether it's with the CSP or whether it's just the other Pentacam functions, to be able to do the show and tell with patients, I think is phenomenal. So Barry, we're going to start to wrap it up here right now. Do you have any closing comments you want to make to the audience, who for the most part have really stuck around all the way through the Q&A?
Well, that's really great. A couple of closing comments. First is, I think most of the attendees that are on this webinar probably are those that are interested in managing irregular corneas. It would not surprise me in the optometric world. I truly feel that in order to manage these patients like keratoconus and similar, you have to understand the disease. You have to be able to monitor the disease and know how to intervene in its management. When we're only measuring the front surface shape or topography of the cornea, it's helpful, there's no doubt, but you're missing so much information and you're not able to truly manage these patients. Now, if you're able to work along with some other cornea specialists who have access to things like Pentacam, that's fine. But if you feel like you truly want to manage patients with keratoconus, I cannot imagine working in that environment without an instrument like the Pentacam. That being said, that's just my own personal opinion. The final thing I'd like to do is to mention to everybody that we at the International Keratoconus Academy would love to have as many of you who aren't members join in to the conversation. We're doing a lot of exciting things, a lot of exciting webinars coming up. Actually, Renato Ambrosio is going to be doing some of his newest work on a webinar that we're putting on at the end of this month. So if you're interested in membership, please go to our website. You could see it there at www.keratoconusacademy.com, and you can join in. It's complimentary. Our industry sponsors, such as Oculus, allow us to continue our education to the eye care world without charging anybody for membership. So please join in.
Yep. Barry, in closing, I would really echo that part. What you and the board and the members of the International Keratoconus Academy are doing is just terrific. Keep up that great work. I think it's starting to really build some momentum now to gain in the understanding of how we can better manage this type of irregular stigmatism. In closing, I'd also like to thank the Oculus folks for putting this on tonight. I think for all of us that had the opportunity to attend, it was time well spent. And if you want to have further information, visit the Oculus website, where there also will be posted a recording of tonight's lecture as well. Barry, thank you so much for your time. It was phenomenal.
Thank you, Craig, and thank you to Oculus, and thank you all for attending. Really appreciate it.
Good night, everyone.
Good night.